of the Birrarung, Melbourne Convention and Exhibition Centre acknowledges the traditional owners of Naarm, the Boon Wurrung and Wurundjeri Woi Wurrung people of the Kulin Nation. We pay our respects to elders past, present, and to elders of all First Nations communities visiting the Melbourne Convention and Exhibition Centre. We recognise the significance of the Birrarung to traditional owners as a life source and a meeting place, and seek to honour a 40,000-year tradition of building community and exchanging ideas on these lands. My name's Jessica Stokes-Parrish. I'm an ICU nurse and educator, and I join you today from the lands of the Kombumerri people in Queensland on the Gold Coast, and I'm joined here with Ian.
Thanks, Jessica. Ian Summers, I'm an emergency physician and a simulation educator, and on the topic of today of gender equity, I'm curious and keen to learn.
It's going to be a great conversation.
I think so. So introducing also on my right, Chris Bowles is the Twitter moderator for the session. She'll be using, which hashtag are you using today, Chris?
Coda22, and it's at Coda Change.
Great, thank you. So please do put in comments, do put in questions. We may not get to all of them, but if you start that conversation, it can also be finished offline later in the day as well. So please do use the social media to keep that conversation going. I'd love to meet the panel. Do you want to?
Yeah, absolutely. So we're joined by this wonderful, esteemed panel who I'm very excited to talk to today. And today's session is going to be a little bit different, I think, to yesterday's. It's going to be very conversational and an opportunity to explore some of these really important issues. So on my left here, but your right, I've got Dr. Sarah Young, who's an intensivist, an educator, and a co-founder of the Women in Intensive Network for ANZICS. And we've also got Associate Professor Nada Hamad, haematologist, activist, intersectional feminist. And last but not least, we've got Professor Zoe Weiner, Deputy Secretary for Public Health for Victoria's Department of Health. In her previous life of her career, as we all seem to have many diversions through our careers, don't we? She was working in cardiothoracic surgery, and she holds a PhD in sex differences in lung cancer.
Thank you. Now, you may have noticed as you came in that there was an operation running on the stage, and I think what we might do is now cross and see what's going on over there.
So, Jono, you're a Chelsea man, aren't you?
Yeah, I am. After you told me all about the EPL, I'm really got right into it.
Oh, it's incredible entertainment. It's such a shame that their matches were cancelled this weekend. You know, Chelsea have interesting transfer market. They spent 250 million, I think, staggering money. And you know, new guy Graham Potter's come in. It would have been nice to see what he could do on the first day.
Yeah, Prof, I reckon that will be a real good thing to look to in the next few weeks, hopefully, when the EPL season starts back up again after the cancellations.
Absolutely. And how about you, Sasha? You got a team, or do you like sports at all? What do you do?
No, not really. I'm not particularly interested in EPL.
Oh, okay.
I was just wondering why this patient elected to have a delayed reconstruction in a DIEP flap. Was she not appropriate for immediate reconstruction after original mastectomy?
That's a very astute question, Sasha. And you've just joined the team last couple of weeks, is that right?
Yeah, that's right. It's my first year as a reg.
Right, okay. So you won't have met this lady in our clinics.
No.
She's 38-year-old lass. She's had a really rough trot, and chemo and radiotherapy it's been very, very difficult for her. Unfortunately, with everything COVID, we've been struggling to get the breast and plastics teams to be able to coordinate a time for her. She's had a number of cancellations, and hence the delayed reconstruction. And in fact, I'm just very pleased that she wasn't on next Thursday's list. I spent most of yesterday speaking to my private patients to reorganise that list, so I'm very glad we could get her in today. And Sasha, so you're first year trainee, is that right?
Yeah, that's right.
What are you looking at doing long term?
Well, I know I definitely want to do surgery. I'm not really sure which avenue I want to hang my hat at, but I think vascular and plastics are the forerunners. I find them really fascinating.
Fascinating, yeah. They are. It's a very hard training journey, vascular and plastics, and you're going to need to make sure that you have things set up well, and if you're going to be combining a family with your training, you're going to need a nanny and some backup and set up. I've got a daughter who's first year med actually, and I'm already having those conversations with her about choosing an appropriate specialty, something that she can do. I was here at midnight last night putting a finger back on. It never really stops. Never really stops. Obviously, if that's what your passion is, have a good crack at it. Have a good crack at it. We're a great training center, and this is a wonderful place to train, and we do need more women surgeons. I think I just stuffed up there again. It's really important that someone speaks to these young girls about what's ahead for them. I don't want them sleepwalking into training that takes over their life. It's really hard. I wouldn't want my daughter doing that. I'm trying to find the words to express that. I don't think I did that well there, and probably shouldn't have done it in the operating theatre. But I'm keen to learn how to do this better. I want to be able to find out how I can guide people properly and help them. So I'm here to learn.
I'm furious. I am so angry and frustrated that in 2022, I need to put up with the same shit that my mother and my grandmother's generation, for that matter, had to tolerate. I had to stick a smile on my face and put up with people asking me questions about what I'm going to do with my future and how that's going to impact on children I don't even have. I want to tell him to pull his head in, but I can't. I need him. I need him to teach me. I could learn a lot from this rotation. I want him to be my mentor. I want him to be my referee. I really need his support. So many of my friends have been lost to the specialties that they love, or to medicine and nursing completely. I want this panel to explore the problems that we're having and see if they can find some solutions to it. And I really hope the men in this audience can be motivated to become our allies.
I'm angry too. And I'm sad. I lost my breast to cancer. I'm tired of the chemotherapy. I've lost a peaceful life with a certain future I once had. I know the reconstruction requires amazing skill and patience. And I understand that only few people can do that, so I'm grateful for that surgeon. But every outpatient clinic appointment was full of male plastic doctors, registrars, consultants. How do you talk about what options you have when all you want to talk about is what your breast means to you? What your sense of being a woman actually means? Your sexuality. Your identity. There were thoughts and pain I never shared, and questions I couldn't ask. So I want this panel to talk about why women in healthcare matter, both as patients and as clinicians. And I want them to talk about why organizations and health systems should care enough to make the changes. And I need them to act. Enough.
Thank you. So our panel and our session's been given quite a powerful agenda by the trainees, by the potential allies, and most of all by the patients that we care for. So as a general structure of what we're going to do, we're going to be looking at why we should care about gender equity, but also look at some of the solutions that can be put in place and how to motivate others. Crossing to my panel, can I ask you, perhaps Zoe, if you can start, perhaps your impressions and why it is that gender equity is something that we need to address?
Thanks so much for the question, and what a compelling piece of drama to start it off. I think it highlights several things. I mean, firstly, that if you can't see it, you can't be it, right? So we've got to have women in really senior roles as role models. I think at times women and men can do leadership and mentorship quite differently, and if you are presented as a woman with a role model who is male, sometimes it doesn't quite resonate. I think the other really powerful piece that comes through in that piece of drama is what it means to the patient. I certainly, when I undertook my PhD, literally by accident, I split up, in the statistics, threw up a pretty stunning difference between men and women in one of our research areas. And I was primed for it because my mum had done a PhD in sex and gender in healthcare, so I'd certainly had my eye out for it. But if we had not split by sex, we wouldn't have actually understood how something was prognostically valuable in men and not at all in women. And it just looked like a mild prognostic signal. So we need women in senior roles within healthcare because they are the ones who notice that the women are missing from the clinical trials, that the women, or I should say the female animals might be missing, and again, looking at sex in basic cell line research as well. So I think it's really critical not only to the workforce, but also to health outcomes.
Yeah. Zoe, Nada, I suspect you've both got an interest in some of the effects on patient care. Can you give us some examples of where that has made a difference and where there are examples of disadvantages to patients?
Do you want me to start off, Nada?
In terms of how it makes a difference to patients, gender equity, I'm going to step back a little bit and talk about intersectionality for a minute, because gender equity is predominantly a movement that arose from a white supremacist movement. So it's very centered around whiteness. You can't really address it without addressing racism. So my view on this is you have to be intersectional, not just about ethnicity, not just about gender, but amongst other intersectional identities, including disability, neurodiversity, obesity even. So, thank you. So addressing all of those biases, you have to do them all at the same time. We can't just do one after the other. We'll never get anywhere. It'll take too long.
Yeah.
So in terms of how it affects patients, it is very clear in the literature that patient outcomes and healthcare disparity outcomes are very much both gendered and related to race or ethnicity, because they're not both the same thing, amongst other biases that we introduce into the healthcare system, either through what questions we research, what questions we ask, how we answer those questions, how we implement them. So even the drugs that we test for and the studies that we do, even for example in my specialty in leukemia, we find that the things that we assume to be true about all of people are actually not true. So I transplant patients who have a particular acute myeloid leukemia with a genetic mutation, only to find that that mutation and the positive prognostic factors will allow me to tell a patient, you don't need a transplant, doesn't actually apply to black patients. In fact, it was never researched in anyone but white patients. So all the algorithms, all the science that we built on all of that was in fact entirely inapplicable to either women or people who were not white.
Yep.
And Australia is the first white English-speaking country to be a minority majority. 51% of Australians are not white. And that scenario back there was entirely white, and that's not an uncommon scenario, both for me as a physician, clinician, but also as a patient. And I've recently had the experience of being a patient, and I can tell you for sure, it is not the same having female clinicians, having female nurses look after you, but even more so, much more richer an experience for having someone who looks like me, look after me, connect with me and understand me beyond what I get every day, which is amazing. All of the doctors, all of the nurses who looked after me with such care was humbling, because as a doctor, I was very proud to feel that we all show up and turn up to serve, to care for others. But the connection and the sense of being cared for and the attention was different from someone that looked like me. And so it is on us as clinicians to understand that in order to serve our community, we have to make sure that we offer them and give them what they need, which is clinicians, healthcare workforce, teachers, scientists, researchers that look like them, represent them, and will represent their needs and address their needs.
Yeah. Can I ask, Sarah, as you went through your training and now you're quite senior in your intensive care unit, to what effect were your career choices shaped by the voices around you, and what was it that you would have liked to have assisted and broadened you in the way that our trainee was speaking on stage before?
Yeah, thanks for the question, Ian. This case really rings true to home because I can remember a lot of very similar interactions when I was deciding which specialty I would do. It's very common for those around you to put forth their opinion on whether you should pursue a particular specialty, which is incredibly frustrating as a trainee. We know from data that men feel that women are less attracted to high-powered specialties such as critical care. But when you survey the women themselves, this isn't actually found to be true. And of course, those sort of expectations will then filter into everything, your interactions as a mentor, as a supervising clinician. And these conversations shape which direction your trainee takes. One thing which really stuck out is the assertion from that simulation that it's a tough specialty, it's not family friendly, I wouldn't want my daughter to do it. I guess what I have to say from that, and drawing on my own experience, is you can be that change. You know, there's nothing stopping you from being the first woman to work in an ICU part-time, which was the case for me. No one had done it for 10 years. There's nothing to stop you from being the person to arrange a high-quality part-time position in that department, to establish change for the benefit of that specialty. And the reason why I think that this is so important comes down to both the specialty itself and patient care. So we want to attract the best doctors to intensive care medicine, and we want to do that. We don't want to miss out on half of the pool simply because they're female. And the way that you can only do that is through representation and mentorship. And as Zoe said, you can't be what you can't see. So in order to attract the best intensivists, but also in order to represent the community of patients that we serve, as Nada mentioned, you need to draw from the full pool of doctors and medical students out there, and you can only do that through equal representation.
Great, thank you. Now, I'm very conscious that I've got a justifiably proud nurse sitting beside me. And if I may ask you, Jess, to what degree is some of the inequity across pay particularly, but also opportunities, actually a reflection of medicine and nursing, particularly as you get high up into the admin sections of either government policy or hospital administration? How much of that ceiling is actually gendered, but some of it is potentially nursing as well?
Yeah, it's interesting. Ian and I spoke about this because I kind of said to him tongue-in-cheek, you've got a panel full of doctors and a scenario about doctors. Where are the nurses? So I'm here to proudly represent. But interestingly, so nurses think that there's no problem with gender equity within nursing, but there is still a gender pay gap within nursing, even when you account for factors like part-time, years of experience. We often see men in particular will take on leadership roles much quicker. So within their 5 years of graduating, they'll often have a leadership role, which is not typically the case for females. And the other thing is that in those leadership roles, we do have a disproportionate amount of men. And, they have the skill, they've got that there, but we do see, there's about 10% of the nursing population that are male. And but the other thing for me that really resonated that Nada was saying was the idea of intersectionality, and for me that just really sings home, because I think in nursing we bring a lot of historical aspects that weaponise and perpetuate racism, biases and prejudices against disability, and we can be a very, very rigid workforce that does not consider equity, and we love a guideline to the detriment of patient care and access.
Okay, thank you. I think perhaps what we might do is start to move forward to some of the pandemic effects. Is that okay? I know we've only scratched the surface of why gender equity is important, and we'll come back to some of the sections that have been raised so brilliantly by the panel as well.
Yeah, so many of these issues, as most of us know, have been amplified by the pandemic, and we've seen United Nations, etc., really highlight in the literature and demonstrate in the data how women shouldered the burden of carers' responsibilities, and I'm sure many of us have stories about homeschooling while trying to teach or try to do a clinic, and it kind of taking that load. And it was particularly pronounced for people who were pregnant as well. And so we want to invite you as the audience to reflect on the impact of the pandemic from a gendered lens. And to do so, we want to share some excerpts from Professor Marie Bismarck's book, Experiences of Healthcare Workers in the COVID-19 Pandemic, in their own words. Now, Professor Bismarck can't be with us today. She's over in New Zealand, and we're really grateful for her permission to be able to reflect on some of these impacts during the pandemic.
I've struggled with being an employee and a mother of 3 children, all at school. I can't seem to fit all the demands on me into a day well. So I found self-care was the first thing to go, which didn't help me sustain my strength for the situation.
An ICU nurse. The loss of routine with no me time was the most stressful. Trying to keep homeschooling momentum going, then having to go back to work and being in charge and on, when all I wanted to do was cry in the corner because some days had been spent with 3 hours of yelling and trying to keep everyone from having a meltdown.
Doctor, emergency medicine. It was very isolating being at home, trying to teach remotely and homeschool my kids at the same time.
An ICU doctor. Having a caring role for my young preschool-aged children and also my elderly mother is even more challenging during the pandemic. I feel that my older male colleagues have little understanding of how challenging that is. The pandemic has amplified sexism in the workplace.
Anaesthetic consultant. The impact on my productivity as a female academic clinician has felt much more severe than what I observe from my male peers. I'm worried about women's rights and the quest for equality going backwards.
A junior doctor. I went through pregnancy and delivery during lockdown. Lack of support is very stressful. I know many trainees and in similar positions currently, or they're worrying about how they will look after small babies or be able to safely return to work if there is still a COVID outbreak at the end of maternity leave.
Social worker. I'm pregnant and feel the hospital has offered me no support in this regard, particularly given we are in the midst of a health crisis. The general attitude is that you need to leave if you're not happy, rather than the workplace having a systemic look at alternative duties that may be available and the unique challenges a pregnant woman may face during the middle of a pandemic.
A senior doctor. I had to return from maternity leave 4 months early due to staff shortages. I feel that I was robbed of this time with my baby.
So we'd encourage you to engage on Twitter if you've got similar short stories that you want to share, and we'll throw back to Chris in a few moments. But Sarah and the rest of the panel, I'm just wondering, if you have any reflections on that pandemic time, which we are all trying to remove from our brain.
Yeah, absolutely. They were tough times. So I'm from Melbourne, and we got pretty hard in terms of lockdowns and homeschool requirements. At the start of the pandemic, I had 3 kids who were all preschool or younger, and I was on mat leave. So I too came back early from my mat leave to try and get my head around working the protocol changes at work before the predicted second wave hit Melbourne. And it was pretty scary times, going back to work with 3 little kids and not having a vaccine available at that time. It was a struggle to stay afloat in terms of just managing the household, keeping the newborn fed and clean, as well as juggling work and the requirements. In Australia, women shoulder the burden of childcare duties as well as housework, and that the pandemic just amplified all of that, and I think it really affected our productivity and our ability to focus at work during these difficult times. Whatever gender gaps were already there were, I think, greatly amplified as a result of the COVID pandemic, and that was certainly my personal experience. I normally work part-time, but I've been full-time since partway through the pandemic as a result of it as well, so there have been huge changes in the way our household manages the workload because of the pandemic.
Yeah, I can relate to a lot of those things. I remember must have been in April 2020, and I said to my husband, okay, so if I have to go back full-time clinical, I don't want to spread any COVID to you. You'll have to be full-time parent at home. I'll be doing that, and we having all these conversations about how we're going to manage this. I'm just wondering, Nada, what that similar, different, interested to hear.
The question makes me so angry. I was just sitting here trying to think, just calm down. When the pandemic, hit, and every time there was a decision that would come across through the television, I would think, who is in the room making these absolutely stupid decisions? We're going to homeschool. Well, who's looking after patients? It's nurses, it's female doctors. The majority of the healthcare workforce is female, by all accounts. Whatever you want to think of, the majority of people working in a hospital are female. And they're female with a proportion that is the majority with children. So, for us to say, okay, everybody locked down, homeschooling, thank you very much, without even an acknowledgement. That's what the problem is for me, is that invisibility. There is no acknowledgement that additional burden will fall on women without even a thank you or a please or how are we going to do this? And then weeks and weeks later, you can have free childcare without acknowledging again, okay, so you're going to send your kid to daycare. Those kids are going to get COVID, and they're going to bring COVID back home to you. So you're forced into this position of either sending your kids to daycare or school to get COVID so that you can keep working in a situation where society needs more help. Beyond that, I have publicly spoken about getting long COVID, which has a higher risk amongst women for whatever their reasons may be. Women tend to be at higher risk of these problems. 60% of the patients with long COVID are women in their prime. My clinician said to me, you are not to get COVID again. You can't get it again. It might kill you. And I said, well, my kids are going to school unmasked. Yeah. How is that possible? What do you want me to do? And he just said, I don't know. Public health messaging, the policies don't even consider that. And so for me, the anger comes from an invisibility of the problem, which represents a lack of diversity in policy rooms, in the rooms where decisions are being made, for someone to say, hang on, so who's going to look after the kids? What are you asking? And if you're asking it, please be honest about it and don't just hide it in this, bizarre policy. Sorry, that's enough.
I'm very interested to hear Zoe's thoughts.
I was going to say,
working in policy.
There is.
It's my team.
Yeah, I'm thinking, Zoe, that actually, if we get you to reflect on those comments, but also knowing that you as a person at the same time as formulating policy was also probably going through the same things that we all were as individuals. Can you give us your thoughts, please?
So I guess at the beginning of the pandemic, I was actually working at Bupa, and I was supporting the aged care business during 2020. And, you know, I was deeply moved by the courage, by the passion and the commitment of aged care workers and the challenges that they had, that they would turn up to work every day and knowing the risk that presented to them, and dealing with the death that happened in their community, in their workplace. These people weren't just you know, residents, they were actually part of the community for these aged care workers, and they also, some of them got very sick and ended up in ICU, but you know, really had such extraordinary commitment to the residents. And I often almost felt guilty that I was remote and I would be trying to support them as much as I could, but just really you know, moved by, as I said, their courage and commitment. I think the other bit, before we get to the policy part, I just wanted to flag as well, and Nada, you started to touch on it a bit there, is there are really significant sex and gender differences in COVID, and it feels to me like we are making the same mistakes we have made in cardiac, we have made in orthopaedics, where we have mountains of evidence of the difference and the poor outcomes that women have, and yet we just keep doing the observational studies to demonstrate the difference. We're not translating that into meaningful healthcare outcomes, or even, you know, the curiosity to understand the difference, because there might be powerful biological tools that we could turn into therapeutics if we could understand that. I'm sure this audience is very aware of the MJA study in 2018 that showed if you're a woman in Australia and you present to an emergency department with a severe heart attack, you are half as likely to get the care you need as a man and twice as likely to be dead in 6 months. Now, I don't know how that doesn't galvanise our policymakers, our national bodies into action. It's a quality and safety issue, it's an economic issue, it's a productivity issue, and we are doing the same thing with COVID. So, you know, as Nada said, we know that women are at greater risk of long COVID, most likely because of sex differences in autoimmune disease, which we already know. We know that men are at greater risk of severe COVID. Again, that's not new knowledge around understanding infections in the immune system. And yet, when we were developing diagnostics and a lot of the vaccines, we neglected to look at that yet again. I think the other element for me around the gender inequity in COVID is PPE is designed on men's anatomy. The majority of healthcare workers are female. There again, we are putting our healthcare workforce at greater risk with this kind of unconscious bias.
Yep. Reflect, like in no way wanting to diminish the enormous effect that it's had on all of us. I'm wondering also and curious as to whether or not there have been positive effects of the changes in the way work is done as a result of the pandemic that's made working from home more flexible, or anything else that's touched on you all. And Chris, I'm going to be looking for you in this one as well, because I know you juggle the same sorts of difficulties that others do as well.
I mean, theoretically, there are some positives. So you can be involved in a meeting from home. You no longer have to be on site to participate, which I guess leads to a different sort of dilemma, because then it's very hard to create that separation between work and home.
Yeah.
Thank you.
Yeah, and I always come back to, you know, there are sectors that can work from home quite easily. Healthcare's not always one of those. I can't do the nighttime, you know, hair wash in the ICU from home.
Sarah, you and I spoke about this a little bit earlier on. How have you found some of those effects of trying to juggle the two things and attend meetings and those sorts of things? Are there benefits to the changes of online meetings or anything else?
Yeah, there's definitely a benefit to having that option of engaging with a meeting online and doing it from home on a day off, so that you can still juggle everything else that you need to do on that. It allows you to sort of participate more in things that you normally wouldn't otherwise attend. But I was just reflecting with you the other week of the different way in which, say myself, when I was on mat leave with a newborn, juggling an online meeting versus some of my male colleagues who have newborns juggling their meetings. So often they'll dial into the consultant meeting, video on, little baby in view, just honed in on the meeting, resting peacefully. Whereas whenever I did it when I was on leave or had a newborn, video was off. I was always trying to get dinner on. I was, trying to sort through piles and piles of washing. I was always multitasking. I never had that luxury of just having the video on and my beautiful baby behaving in front of the screen. So it has definitely been positive, but it's subtly different, my experience.
I'm just going to remember that on your day off. And I think that in some ways sums up some of the real challenges as well, as you're alluding to, is you do get that creep into your home life or the drive home or attend meetings whenever you can. So thank you.
I think we began to kind of address the policy issue, and I know certainly I've been doing some work with you, Sarah, and a few others around gender equity stuff, and it can be pretty damn depressing to keep reading this stuff as a woman. And I'm just wondering, I'm going to throw back to you, Zoe, around the policy and the interested in your reflections on, I guess, leveraging some of that. Like, how do we begin to shift the lever on some of this stuff? Because, to be fair, it really feels like we've been talking about this forever. Like, it feels like we're hitting our head against a brick wall, and I'm kind of sick of doing that.
That's kind of the $64 million question, really, isn't it? How do we implement this stuff? And when I talk to my colleagues around the world who are leading experts in sex and gender in healthcare, and I say, who's implemented it? The answer is nobody. And I think that's what's on us as an opportunity, but also an absolute necessity. There's a couple of really interesting barriers that I have, in my journey, become aware of, and I've shared with some people in the past, but when I was an intern and I presented to my cardiology team, wanting to make a good impression, it was a New England Journal paper, and it told us everything we've been reporting for years and years. It takes women longer to get to the cath lab, they have worse outcomes. So the cardiologists started to furiously agree with each other that they didn't treat their female patients any differently, which might in part be the problem, but anyway, until the professor of the unit said that's an interesting study, but we can't be expected to undertake research into all minority groups. And I thought to myself, intern career-ending moment, but I have to do it. I think by definition, Professor, that 51% of the population is not a minority. But what that really revealed to me was a deep unconscious bias, because he immediately realised the error, almost before I pointed it out to him. But I think we are still fighting that unconscious bias, and I think it's a major barrier in how we actually start to implement some of this. I'm aware of another cardiologist who worked really hard to get that cath lab time to be the same, couldn't do it. And I think the other really interesting barrier is, or one of them, there's many, is the assumptions we make about sex and gender. There's a fascinating study that was looking at pain response in animals. And they did control and have equal numbers of male and female animals, but they were still getting really discordant results until they realised the animal was responding to the sex of the observer. So if the observer was female, the animal showed pain. If the observer was male, the animal did not show pain. Now, when you start to unpack that and think about all of our studies and the assumptions we have made, it's pretty terrifying about actually how little we've taken this into account. So I'm really grappling with, and I welcome any guidance on this, how do we start implementing this and stop just producing observational studies? I think we've got the evidence, it's a problem, it's having a huge impact on our workforce, on our patient outcomes. We've got to do something about it. And I think some of the levers I've been toying with from a policy perspective is quality and safety. Is that the lens that we need to take some of this conversation into? Is it about economics and productivity? We have a healthcare system that is facing extraordinary unmet demand, long elective surgery wait lists. We absolutely have to understand how we get these elements of low value and high value care right in order for our healthcare system to be able to be sustainable.
Nada?
I'm itching to say something.
Go. You've been sitting there on the edge of your seat.
Yeah.
Because I totally agree with everything you're saying, and I think sometimes in Australia my feeling is that there is a denial, a personal individual denial. It's always somebody else's problem, it's a policy, it's a result, it's a vexing issue, what are we going to do? And I want to challenge everybody in this room, we've got a captive audience, to take on individual responsibility. This is hard work to confront the concept of individual bias, because it's uncomfortable to feel that you potentially may be implicit or complicit in perpetuating inequity, injustice. we are here every day to do good. We have a calling as healthcare professionals to do good. So it's really hard to accept or acknowledge that perhaps we may be perpetuating injustice. And I say this as someone who is a Black woman that realized very late in life that I also held sexist and racist beliefs. I didn't realize this until I had to sit there, do an implicit bias test and go, oh my goodness, I am both sexist and racist. And I think the important takeaway is that everybody has to come to that in their own time. It's a personal journey. It takes time, it takes work, it takes reading, it takes learning, it takes effort, but it starts with you because you don't need a government, you don't need policy to help you appreciate that. We cannot move the needle forward unless we are all in this room accepting and acknowledging that we hold these biases and that you can actually change that. You know, I'm as competitive as anybody in this room. You know, you don't get to this place without being a little bit competitive, and it was my mission to fix that result on that implicit bias test, and it got better. So, you know, my only positive about that is that it does get better. And what it takes is decentering yourself from these conversations. It's not about you, it's about the people who don't have power, the other people that you can't see, the invisible. Once you see it, you can't unsee it. I would encourage you to look up the Wheel of Power and Privilege, you know, read about intersectionality and recognize that everything we do in society and culture is built around the few who hold power. And learning to see the people who are not in that center will enrich your life, will make you a better clinician, a better doctor, a better parent, a better everything. So if not for you, I don't know what else to say. I'm compelling you to do it for you because you will be the change with that simple act of acknowledgement and decentering yourself.
I've heard this thread come through a few times now, and that is this idea of decentering yourself and this idea about partnering with people. You know, assuming that we don't have all the answers and that we actually need to open the dialogue. And I believe that Karen Price yesterday said this in her talk, that we don't dialogue well. And I think that's part of the challenge around answering some of these questions and addressing them, is because we're asking the wrong questions, but we don't have the right people in the room. And some of those right people in the room are our patients. And I think we're going to come back to that and explore that a little bit more. I'd like to kind of explore that idea of partnership a little bit more, because I think it's it's easy for us as health professionals to think we've got the answers within our little area of expertise and to know that there's more out there. But I think we're going to go to our next scenario now, Ian.
I think so, yeah. So perhaps if we could get the team into position to orientate you to the space, because it'll take probably a minute for them to set up. We're now moving to an interview room in an office space of an emergency department, and the interview isn't taking place. The interview's in that sort of phase where a couple of the quite senior emergency clinicians, perhaps the director of a department and the director of emergency training, are both discussing candidates before the arrival of HR and before things become a bit more politically correct. So if we could allow ourselves to buy into that space. Team, are you in position and ready to go? Fantastic. If we can cross across there.
Hey Sasha, how are you doing?
Good, how are you?
Tom and Helen are outside, and I've just heard HR is going to be another 5 minutes or so we can have a bit of a chat.
Yeah, sounds good.
How was your shift last night?
Oh gosh, you know, it was really busy. Resus was full all night. I mean, it was good fun, but it was relentless, and the waiting room was packed even when I left, you know. Same.
Absolutely. I know you've been doing some extra shifts recently. You're just working a bit hard.
Yeah, a little bit. Everyone's sick. I mean, you know, we're just trying to plug holes where we can, but there's no way around it.
Yeah. Kids all right?
Yeah, well, in all honesty, haven't seen them for a few days, but as far as I know, they're doing all right. No big complaints.
Good. All right, well, yeah, we've got Tom and Helen, two good candidates.
Yeah.
What do you think?
Well, is Helen still having problems with the nurses? I'd heard she'd been like quite aggressive and autocratic. Has she managed to rein it in yet, do you think?
I think so, yeah. Listen, I'm a big fan of hers. I think she's a lovely, warm person, and you know, she has been viewed as a bit aggressive by the nurse in the past, but I know she does a lot of social stuff with the nurses, and she's posting on Facebook, and she always bakes on night shifts apparently, and yeah, so it's pretty popular. I know that the junior staff really like she's taken on that kind of nurturing role for them. So it's just she's a really nice person, I think.
She's a young mum herself, isn't she? How old's her little one? 2.5?
Yeah, I think so. Her husband is a cardiology fellow. He's kind of a bit of a high flyer, and he's doing some fancy research projects, so he flies around a bit. And
oh, that's interesting. Yeah, it's a real shame. Every time my little one gets sick, she seems to just always take carer's leave. I had to cover one of her night shifts last week. It's exhausting.
Yeah. I don't know. I think you go past 40, night shifts get harder, don't they?
Definitely. Although obviously I'm not 40 yet.
Oh, absolutely. It's just a warning.
Yeah.
So yeah, it's Tom. So I think about Tom. He's great. I think he got the prize when he did the exam. His presentations are always fantastic. He's always up to date with the science. You've got to drag him out of resource. He's the first one into resource. He's at procedures all the time. He's always there, always ready to kind of step in, and got that kind of leadership thing about him.
It's quite impressive, isn't he?
Yeah, he is.
It's a shame we've only got one consultant post and 2 good applicants.
Yeah.
Okay, so we've got 1 consultant job and 2 senior registrars going for that job. And I'm not sure how much our panel could hear of the different aspects of that conversation. But did any of that strike a chord on you of the way that they spoke about those candidates? If you could see them, there was probably some nodding going on and a little bit of seething anger going there as well. Please let us know what you think.
That definitely, made me see the little bit on the inside. It reminds me of a very similar situation where 2 registrars who were going for consultant jobs, who'd worked together on identical projects, had very similar, near identical CVs. The male got offered the job interview, the female did not, and she was pregnant at the time, but very early so. And it just sort of reminds me of that situation, which happens countless times in real life. So definitely.
Nada? I like how subtle that was, because it's not sometimes even that subtle,
Yeah.
I've learned in my years to have to be undeniable in my CV. There cannot be any doubt that I am the best, if not 10 times better than my competitors. And that's a hard thing to have to do. And not only be better, but also bake. And also have to answer the question of, who's looking after the kids? Not, hey, that paper was great.
Yeah.
The kinds of conversations, even in my networking events or in my conversations with people that are potential employers or collaborators, with my male colleagues, it's golf, sport, and then straight to your credentials. It's a connection and then credentials. For me, it's like, who's looking after the kids? Oh, you must be doing it so hard. How do you do what you do? When do you sleep? And you're so nice. So, enduring all of those microaggressions, and I don't forget all the microaggressions that come with being black too. I get those too. But, having to endure that every single day creates a certain resentment and a certain recognition of what is happening around you for others. So not only do you get angry for yourself, but also seeing it for others, your colleagues, the juniors that you mentor and support. I exclusively will push very hard for my female mentors and mentees and juniors. And that also is work that is added to my burden that I don't see my male clinicians doing. So not only do I have to be better, I have to support more, I have to bring forward more. So allyship from male colleagues is great. It just takes a little bit of the load.
Yes.
And then I don't have to take it out on my husband, when I get home.
Yeah. Yes. Exactly.
So don't get mad at him.
Zoe.
I think that the word allyship's really interesting there. The Secretary of the Department of Health, Ewan Wallace, for those who don't know, is an obstetrician and gynaecologist, and he almost exclusively uses the pronoun she, particularly when he's talking about more and more senior roles. And he doesn't even think about it, like it's inherent. And I still have to ask him the story behind that, but it really stands out. Because I watch a lot of even my female colleagues who don't do that, who automatically use pronoun of he, and so for me that's that is that allyship. That's demonstrating it right at the top. I mean, I couldn't hear that very well, but I certainly have similar experiences of being a cardiothoracic surgical trainee, being enrolled in an MD, wanting to convert it to a PhD, and being told by somebody very senior, Zoe, you're a woman, you're going to want to have children, you can't do it all, you're either going to be a researcher or a surgeon, choose. And thinking to myself, no way am I accepting that, that just incensed me, that person thought that was okay to say to me. Yeah.
I was told once if I wasn't pregnant, I would have gotten the job because my CV and my application were excellent, but I was pregnant. So it's not always implicit.
No, it's not.
It's
no, you're right.
It's
just coming to mind an interview that I had a few years ago and went really well, and I got to the end and one of the panellists said to me, but how are you going to manage having a full-time job and children, young children? And I just looked at her with seething eyes and just said, it'll work. But apart from the fact that that's completely illegal to do, but, it just happens. I'm quite interested to hear, Ian, you're kind of sitting here listening to us vent and also, talk about the importance of allyship. And it's so true, isn't it, Nada, that the fact that I know that I can have a conversation with you, Ian, and you're not going to get offended because I say a middle-aged white male. Or maybe you do get offended, and now you can tell me.
Oh, God, do I unmask the offence? No, I don't. I've had discussions with all four of you and with Chris over many months before that, and Marie Bismarck as well. And I was keen as I worked out why I was here and whether I should be here, of an understanding about the fact that my intentions were good, and that so much of what I find as I explore issues like this is if I can ask the right question and understand more, and if I get that question wrong or I phrase something wrong, and almost certainly I will or have already in this session, that people judge my intentions as being pure. Once you have that ability of respect, then you can actually engage in the conversation and understand. And I think independently, Sarah and Nada and Zoe all said something so similar to me without me asking about it that made me feel so much more comfortable to be here, and Chris before that. Perhaps if I may push it back on reflection to you, if you're enlisting or motivating a male ally, what do you think the keys are of engaging them? Not so much instructing how they should do a better job, and I do want to get to that, but how do you find you are best to engage people?
Yeah, it's a real challenge, and I think this concept of unconscious bias, there are a lot of people out there who don't buy into it, and I think that represents the first and hugest barrier that we have in the work that we do, that people don't exist, that these implicit biases exist and that they're a problem. And what I found useful in the past is separating the implicit bias itself from one's moral compass. So an acknowledgement that we're all part of the same cultural soup, and we all hold these implicit biases, whether you're black, white, male, female, we're all part of the same cultural soup with subtly, different life experiences. And that it is not your fault that you hold these implicit biases, that everybody has them, and by holding them and thus behaving as a result of them doesn't make you a bad person. If you can get that point across to your audience and encourage them to sit back and listen to your real life stories and experiences and bottle up any defensiveness or comment, then that is how we will start to make progress. I think this ties into the concept of allyship. This is how you then get men who, dominating the positions of power to engage in meaningful change. And I think this also speaks to the minority tax and the burden that this kind of advocacy work bears on the minority group, particularly if you have any other minorities associated, such as a non-white skin colour. It's, data shows that men get, men are at an advantage when they are engaging in diversity, inequity work in the workplace. Women don't necessarily bear that professional advantage when they engage in that sort of work, which is why it's so important to bring both parties. But I think the ability to discuss and acknowledge unconscious biases and separate it from one's moral compass. It doesn't mean that you're a bad person if you hold them. It's quite normal to have unconscious biases, is the first step in engaging people to have real conversations about it.
I'll say a couple of things. You know, sometimes people say to me, how do you engage men? How do you bring, you know, your white colleagues into this? And part of me wants to say, why is it my job? It's not my job. But what I will address is the discomfort that arises from people talking about these things, and some of the things my friends say, which is, I don't think this problem exists, for example. I don't think sexism or racism exists in 2020. This is not a thing. And it's an unusual thing to say because, you know, as doctors, somebody comes in with abdominal pain, you don't go, this doesn't exist, you know, it's not real. If someone is expressing to you a real lived experience of either pain or suffering or struggle, the only normal thing to do as someone who cares, or a clinician or a physician, is to acknowledge that experience and go, oh, this is happening to you, tell me more, or let me understand this so that I can reflect on it and perhaps, you know, assist, because we all want to help. So I would appeal to your sense of wanting to assist or wanting to support others, because I know it's in everybody who is in this room. The second thing I would say is people get really worried about being cancelled and being demonized and being called a white man. And my answer to that is, don't be so fragile. You are not going to get canceled. The power lies with you in everywhere you exist. You don't have to deal with so many of the other things that other people do. And so what if you get silenced just for a few minutes? You know, it's not the end of the world. You know, cognitive behavioral therapy about catastrophizing a situation. It's not the end of the world if you don't get your say or your opinion is not the loudest in the room. Perhaps it is more rewarding to allow someone else to speak. And I would encourage everyone to think about how you would elevate the voices of people who don't normally get to speak. You know, whenever I get invited to a talk, I'm always looking for the person who's even less privileged than I to have an opportunity if I can bring them into the circle. So, you know, those moments are actually very rewarding. I think that the defensiveness comes from a place of discomfort. I think it's okay to be uncomfortable. I think COVID, when we talked about the positive things COVID have shown us, is that we are extremely capable of change very quickly. We can change the world in seconds depending on who it matters to. So make it matter to you, and you might feel different about the speed of change, the magnitude of change. And you are certainly a very powerful person in this conversation. Everybody in this room is. So, you know, I think you have a lot to say and do.
There's a few reflections. One. Sorry, Siri. Can Siri sort
what
this
would
out?
you like to say, Siri?
Siri,
Siri, would you like to talk about the bias in AI?
Why is my Siri a boy?
So for those who know Professor Roger Short, he worked at Monash in Melbourne and has done extraordinary work. And one of the things he used to say to me was, find the silverback male. So find the ally, find the champion who gets this and work with them. I think also, at the risk of giving away one of my tactics when I talk about sex and gender in healthcare, I include men. Often I hear gender used almost interchangeably with female or women, and in actual fact there are areas where men have significantly worse outcomes in healthcare, so it's kind of like a bit of a tactic of what's in it for them. Yep. And mental health's a really interesting one, where a lot of the diagnostics have been, and anxiety and depression have been developed on women's symptoms, and men have different symptoms, and we potentially, causality is not demonstrated, potentially have worse outcomes as a consequence. And I think the other reflection I have, partly to the previous conversation as well, as I was the chair of a board, and in that role had the pleasure of being reviewed regularly by my colleagues. And one of the pieces of feedback I consistently got was, Zoe could be warmer and Zoe could be friendlier. And I did just reflect on that. Maybe that's true. I'm certainly not defending against it. I'm an introvert by nature. But I also thought, wow, I wonder if I was male, if that feedback would have come. Felt pretty gendered.
Yeah, we did construct that interview discussion, and there was a whole section about how the female trainee had been perceived as aggressive, but was now really valued for that social networking, collaborative approach that, you know, the words they used was like, she's a real mother to the juniors. And that in an emergency department is seen as a really strong team asset. Like that is actually rated as something that you would select that person over somebody else that didn't. But I'm wondering at what cost that comes if you're not that person, and what the expectations feel like if actually that's not you, that's not the way you perceive your workplace.
Nada, go.
I mean, I think there's something to be said for recognizing different attributes, particularly gendered ones, and how they are valuable in the workplace. You know, someone who's a good communicator, who's caring, who's warm. Patients want that.
Yeah.
Yep.
Right? I don't think the patient cares if you're a good presenter or you remember that NEDRM paper and the specific stats in that paper. So what are we actually valuing in the workforce, and how are we assessing the needs of the job? And I think medicine is so diverse. There's so many roles to play. It is not possible to meet all those needs by employing a homogeneous workforce. And people tend to hire people that look like them. And so we keep doing the same thing without recognizing that we need the diversity on purpose, both in terms of skill set, but also in terms of demographics and identities. You know, unless we're deliberate about that, we will never change that. So, you know, I'm very conscious that in North America, for example, they do want a diverse workforce. They will pick the diverse, you know, candidate specifically because they're different. So valuing difference is something I'm not seeing, and I'd like to see more. Bringing people in just because they're different is actually valuable in its own right.
Yeah, and I think what you're touching on there too with those caring aspects, often a lot of the problems that we see in nursing, for example, is that it was originally a caring profession, and we inherently value caring as being a lower form of employment, etc. And we see that with pay, same with teachers and all of these things. And I think you're right, it's this, you know, what do we value? And there is value in valuing diversity, and it doesn't need to be the test score or the OSCE exam. And choosing somebody based on their diversity is not the diversity card.
Yeah.
It is a statement about value, about what we wish to see and how we wish to improve our workforce. Chris, what's coming through online?
There are a few anecdotes coming through.
Yeah.
So our scenarios have been quite subtle, and it appears that real life is actually more outrageous. But it basically sort of backs up what we're saying, that there is some overtly sexist behaviour. I mean, that's not a surprise, but that people are making overtly sexist comments to trainees, particularly in the context of what they choose as a potential career. So that's pretty concerning.
Yeah.
So there's a lot of work to do. So we're talking about deconstructing things on the individual level, but you know, some of this behaviour is probably much more basic than that, I think.
Yeah. And I think we've kind of begun to touch on that with around, okay, so what are we identifying as the values that we want, right? But how do we then build that from an organisational perspective, that it's not then that minority burden of those of us who see it do something? So obviously, yes, we need to be doing that, and we as a community need to be doing that. But what are the building blocks we need to see around removing that individual approach to bottom-up change?
I wonder if there's an element about understanding the value of the attributes that we might actually be devaluing, caring, compassion, they actually lead to better health outcomes. So it's if you focus on the health outcome of the patient, there's been some studies that demonstrate that if your clinician is female, you are likely to have better health outcomes. And I actually presented this at the Victorian Giant Steps conference a few years ago, pre-pandemic, and made the observation that some of the reasons behind that is that women are more likely to follow clinical guidelines, but they're also more likely to spend time listening. And in that time listening, gather really critical and important information. And of course, that doesn't mean that men don't do that and aren't good at that, but that there is a tendency for women to engage with their patients differently in that way. And so how do we actually recognise how incredibly valuable that is when it comes to the patient health outcome as well?
I think in terms of how organizations, institutions can address this is to create an environment where competency in this field is a requirement. So, certain universities have put it into their, academic promotion metrics that as an element of equity, diversity, inclusion, competence is required, or at least desirable, and it should be. Interview questions should ask, what do you understand about oppression, privilege, diversity, equity, inclusion? What does that mean to you? How do you apply this? I mean, it's 2020. This is no longer something that's optional in a profession that looks after people. So valuing that personal reflection and personal responsibility amongst clinicians is really important. I'll put in a plug for a couple of books that are amazing to read if people want to take on that journey of learning. How to Be an Anti-Racist by Abraham X. Kendi, and Pain and Prejudice by Gabrielle Jackson, who's an Australian author. And what really interests me about Gabrielle's book is that it's popular in other countries. It's the most popular in the US and in the UK than it is in Australia. So I always take a moment to say, you cannot not read that book. It is mandatory reading for anyone in medicine. My husband listened to it and he was like, how did I not know this? I'm like, yes, even doctors don't know this. So please, do that work and be proud of it and talk about it in your interviews. Bring in your life experience in your expression of who you are at work and what you've learned at work. And calling it out is really important. It's not the end of the world. So kindly call it out, but do it kindly, because none of us is immune to implicit bias. None of us is immune to these issues. It takes time, so you will get it wrong, and that's fine. We all get it wrong, but it's only a journey into progress.
Yeah, I think in terms of, as you were saying before, it can be damn depressing doing work in this space, but there is a lot of hope in terms of solutions and what we can all do. I do sort of reiterate what other panellists have said in terms of calling on all of you individuals to examine your own biases and to allow yourself to sit with that discomfort and be okay with it and learn and grow from it. Let's face it, no one likes to hear that they got a leg up to where they are today because they were male. Like, no one wants to hear that. But this is what it is, and sit with that and you will grow and learn and be able to help through it. I think a lot of what this comes down to is female representation, and through that, systemic change and shifting away from the individual focus. So instead of simply asking us to speak up louder, do leadership training courses, make ourselves more visible, do unconscious bias training, we need to shift away from that responsibility on the individual to tackling this from a systems-based approach. And this is why it's so crucial to engage men and women in the process, because men overwhelmingly hold the positions of power. We need to engage with local advocacy groups such as ours to develop guidelines, policies, and put in place targets which are effective drivers of meaningful change. And even if they're just aspirational targets where nothing really bad happens if you don't meet the target, it's still something to aspire to. It's still putting something down in paper that you as an organisation can aim for. And so this is some of the work that we've done through our Women in Intensive Care Medicine network, putting in targets for female representation across college academic events, committees and boards, for example. And just having that there allows this conversation to take place to then create meaningful change at a structural level.
So can you perhaps expand a little bit on what you've managed to achieve with that network and the support that you've got and where it's gone from your initial seeding that you once described to me?
Yes, well, it's been a long journey actually. I'm older than I realised, but we started the network in 2015, amazing group of women based in Melbourne, but we've since branched out to cover both Australasia and New Zealand. We started off just by having networking dinners. I don't want to minimise the importance of those. They're absolutely crucial in getting a group of like-minded people in the one room to start the discourse, and that's how we started. From that, we realised that representation of women at our specialty conferences was pretty poor. We looked at it and published a paper on it, and we found that the ICU college was the worst. We were even worse than the surgeons. So from that, we then got... that also coincided with my time working with the college board as the new fellows rep, which was a great inroad to then develop some of these statements and guidelines, which I'm really proud our college has taken on board. We developed a guideline for gender balance amongst college events, and from that got asked to create this guideline for gender balance across the college, more broadly speaking, including training, representation. And more recently, we've also developed a very progressive parental leave policy, acknowledging specifically that parental leave is different from other forms of leave, as it disproportionately affects women, and it's one of the first and progressive policies out of any college at the moment. And then in that time, we've also expanded to cover, as I said, Australasia, to have better representation across Australia and New Zealand to try and further this work that we're doing in the gender balance space.
Great. Zoe, are there organisational KPIs or markers that hospitals or healthcare networks or aged care centres drive towards, and what are the incentives that the system builds in to push into success?
I mean, there's certainly, Victoria's quite progressive in its gender equity plan and requiring hospitals to be reporting on gender gaps, gender pay gaps. I mean, I'm a pretty big fan of carrots, not sticks as well. So how do we actually reward those who are doing well? I think WeHire is a bit of a standout in some of the work they do in really identifying the barriers for women and parents in progressing in academic careers, because obviously, publish or perish, and if you take time out to be a parent, that has a huge impact on your career, and they've done some really innovative work about how you level that playing field and don't make valuing being a parent at the cost of progression in your career. And I think that's a real sort of exemplar for us to think about how we can actually model that more broadly in the healthcare sector.
I want to kind of quickly touch on this, in that often with issues around gender equity and women, we frequently go to the parenting or mothering, but there are plenty of our colleagues that will choose not to have children or can't for various reasons, and I think it's really important to acknowledge that they also deserve equity, and that it's not just about mothering and parenting, that why we're going for gender equity. I'm just wondering if there's any comments on, I guess, policy and different ways, because we get acknowledgement as a parent. I can put in my application for promotion, that it was impacted by child. But I guess I just want to touch on that because I think it's an important point. Anyone have any?
I mean, I think this is a wider societal cultural issue. I mean, we place certain values on being a woman or on gender that mean that we limit people's aspirations, people's career trajectories with no fault of their own. I mean, even if you are a mother, who's to say that's a major part of your identity? I honestly get so sick of people asking me about my kids all the goddamn time. And, they're not even the best thing I've ever done. So I'm like, I don't, I find it really offensive that it's always like,
the default conversation.
The default
Are you
conversation is
yeah.
you're a parent. That must be the pinnacle of achievement. So, I think that the kind of things that people miss out on in the richness of conversation and experience with others is putting all of these additional things in the room. People who identify as women may not even identify as women. I didn't even bring up the issue of pronouns or gender identity or sexuality, but all of these things are really important. In 2022, you've got to accept that not everybody who looks the way you think they look identifies the way you think they identify. And one of the things that I realize is definitely not a male thing to do, is to just ask, how do you identify? Ask what is important to you. What in your career is important to you? What in the workplace is important to you? How do we make this a better experience for you? I mean, you know, I didn't think this was so radical, but it clearly is, right? Because every time I'm in a room, it is amazing the assumptions we make, the conclusions we jump to before we even ask. And that goes for science. And as a scientist, I find that really confronting. Where is the curiosity that makes us scientists and clinicians, right? Like, fall back on that. Just keep asking questions so that we make the room more comfortable for more people. We engage in a richer way. You know, I'm always amazed at the kind of experiences I find amongst my trainees these days. Like, it's just a simple question. Ask, what's going on with you? What's your life like? What do you
what do you
want?
what do you do in your spare time?
I know.
And if they have a family, they can tell you.
Exactly. What do you want? What do you need? Is something that is relatively radical. And I think, you know, avoiding assumptions is something I'm learning as I'm older. And if I was to tell my younger self or anybody else who's coming through, just forget all of the things you learned about culture and society. I think COVID has really flipped a switch in my mind that the world is not what we thought it was. It clearly is not. Look at how it's panned out. Some of the things we've always done have done humanity a disservice. So just rethink everything. It's fine.
So I'm just thinking, so coming back to that organisational perspective and thinking about Coda's mission and what we want to achieve as an organisation, you know, the pillar of equity. And I'm wondering what you think as an organisation Coda can do to help contribute to this change. Big question, I know.
Can I just come back to the previous question for a moment? And just so I'm a woman who's chosen not to have children, and I certainly experienced in my younger years real judgment around that, that I was less worthy or as a consequence. And then, of course, the double bind of, but you can't possibly want it all, Zoe, because, of course, you'll want to have children. So those assumptions were pretty challenging. But I quite deliberately called out parenting because I think the flip side to that is we undervalue fathering. And I don't think that helps our kids either. There's a really interesting book called Children of the Lucky Country, which is written by an economist, a paediatrician, and a psychologist, which really explores how our workplaces don't support women or men to be good parents, and we are impacting the next generations as a consequence. So I sort of wanted to, there's two kind of elements to tease apart there.
And certainly the policies that are in place to make parenting easier, I find as a dad of young kids, it's superb if something is making my workplace more flexible. And I've needed that at different times of my life of, you know, being a single dad at times. And, you know, I read a tweet the other day when you said, Nada, I'm really angry. I got this triggering tweet that somebody was complaining about the time you go into a place and the change table is in the women's toilet. That used to just do my head in when I was a dad, you know, trying to change nappies and trying to juggle swimming lessons and all the rest of it. Anything that can be done that flags this as a sort of an unconscious bias also works to our benefit as well, because those biases exist when we ask for, you know, special leave because we require it at school holidays time, or because we're locked into patterns that we have to observe for other people as well. Anything we can do to add flexibility helps fathers too, so thanks for bringing that up.
So the question of how does Coda help foster this? How does Coda, you know, what can we do as an organisation to really put it as a forefront kind of issue to be addressing of equity?
I think Coda's doing it. You know, I do a lot of conferences, talk about EDI, but having things central into a plenary, that's rare. So I think the idea that equity, justice, both in healthcare and in society, is integral and central to our values, our missions, and what we do, should be reflected in the things that you're doing, which you are. And I think just talking about it year in, year out, and evolving the curriculum that you're presenting so that it's no longer just an additional bonus, but a core to what we do, and centralize it to everything. So centering the right conversations, the right people, bringing in diversity into panels, into discussions, I think that's what we need everyone to be doing.
Yeah, I think keep doing what we're doing and don't sort of underestimate. It does take a lot of work to maintain this amount of momentum. I think what Coda's doing is great. You know, get the conversations happening, keep them happening. You know, put topics like this front and centre on the big stage rather than down a side room. And on a more broader scope, you know, give gender equity the sort of attention and the value that is worth. It is something that, you know, people who work in it should be awarded, just like researchers are awarded for their papers. It should be front and centre stage, just like sepsis research is. It should be encouraged for our trainees to partake in this activity, just like they all have to do a formal project. Give it the worth that it deserves, because it will result in better workplaces and better healthcare outcomes.
And make it intersectional.
Yeah.
I mean, I think I want to pick up on something Nada said earlier, which is, I'm paraphrasing you, so my apologies, but it's not the job of the people on the stage to do this, it's all of our jobs. And I think Coda has an extraordinary network to empower people to realise it's everybody's job to address gender equity in the workplace and inequity in health outcomes.
I think probably what we might do is see if there are any themes emerging from Twitter that we need to address or ask about, and then almost head towards the summary. And we're really looking for those positive outcomes. So I'll plant that because I know you're going to be running that section, Jess. Anything there from Twitter, Chris, that you want to address?
Yeah, I think...
you need a mic.
No worries.
Just to say, you know, a recent powerful comment was that, you know, the boys' club is still quite powerful everywhere. And, yeah, I think that's true. And it's for us, I think, to think about how we actually respond to that. So, you know, actually having a strategy, you know, which we've been talking about. But where my mind goes is to think about what we can do as an organisation at kind of every level. So it's equity amongst speakers, but it's equity for the delegates as well.
Yeah.
And how we actually achieve that. So I think that's where we need to go next.
Yeah. Yeah, and I think the intersectionality is a really important piece, because we do often get stuck on the gender equity thing and forget about the other really important stuff that needs to be considered, and to really kind of pursue that vision of inclusion and celebration of these things, because that's the other part too, isn't it? That we do sometimes forget to celebrate the successes and that diversity, and why we celebrate some of those things. So I want to ask you, as the panellists, the last question, and that is, what's the one thing that you heard from one of the other panellists today that you want the audience, the delegates, to take home with them?
I think I've already said mine, which is it's everybody's job.
It's everybody's job.
Yeah, I think Nada really summed that up. It's all of our responsibility, but also not to say that people aren't stepping into it, but to empower people to step into it, and that the change can come from individuals at their own institution implementing these practices and understandings.
I'm going to pass. I'll come back. You
I think to add to that, that really has struck a chord with me, Zoe. But also that the importance of intersectionality, like this is huge, because the lens through which we experience gender inequity is subtly different based on our individual backgrounds and experiences. And just acknowledging the impact that intersectionality has on all of the work that we're talking about.
Yeah. I would say the example of the changing table. It's one that's so powerful. I'm always like, you do the napper change. I can't do the napper change. It's in the women's bathroom. Damn it. Again, that's an example of decentering one from experiences, trying to think about the perspective that you are not necessarily always thinking about. I think about my worldview, which is, the fight that I have to fight as a black woman in Australia, in the world, in every single room I'm in. And so I don't think about the struggle of a single dad who's trying to make sure that he gets into the women's bathroom. So I think it's always humbling to remove one's experience from the forefront of your mind and then to think about somebody else's. And those moments really make me quite happy. They make me laugh, they make me think. So just listening to that story was really quite a fun moment for me.
I'm not sure if you're looking at me, Jess, because you wanted me to add on that section or something else, but I may, if I can. There's a reflection about how uncommon it is for a conference to run this in a plenary session. And what that means is that half of the people here, and we can't really see all the faces, but even the ones I can see, I reckon half the people here are men. And that is so exceptionally rare. Like if I go into a conference and I go into what's usually called a special interest group of the gender equity, on the rare times that I do, I will be maybe one of one or two men that are there, and I stay very quiet until occasionally I ask a question. I think it's a great tribute to Coda to put it in the plenary session as you did, because it means that the audience that you've got here are the people that are actually also responsible for either discovering the unconscious biases that we have, but also to take action. And I think probably that call to action is really what we want you to start to generate yourselves. Chris, I think probably, did you want to speak about the way that you wanted them to use Twitter for that call to action or personal responsibility?
I would love to have lots of ideas for where we go with this. I'd love to have ideas for micro, meso, and macro actions, feeding into the next incarnation of this conference. Because I think we need to sort of set things down as concrete so that people know how to do the right thing.
So send through your ideas and thoughts and how we can demonstrate and model perhaps that intersectionality around equity across every facet of the Coda program and how we move that forward. And I guess what people need too, what is it that you need from the organisation to support that in your workplace? Ian, you need to de-roll.
I've got a few thanks to make. So I don't know if the lights guys could drive up the lights into this centre section of the stage so that the team can come forward, including the backstage team from Monash Simulation, please. Guys, you want to stand up so that I can say my thanks. There were, with the exception of one person, no professional actors on the stage. The backstage people, Ash, are you here still? And the backstage team as well. Jonathan Devine, ICU Registrar and the Simulation Fellow at Monash Simulation at the moment. Natalie Gomes is an anaesthetist and also a sim instructor with us. Neil Cunningham, an emergency physician at St Vincent's, Melbourne, and a fierce advocate for junior staff across St Vincent's, and a great mate of mine. So thank you for letting me write a role for you and helping me construct a role for you that felt good for you. Sasha Rose, as always, brilliant actor, paediatric emergency physician across in Adelaide. Kath Lamb, and is it Jess? Sorry, you've got a background. Jess Gill behind two of the sim instructors. Somewhere in the background, and she won't be here because she's so shy, will be Kirsty Murtagh, who usually hangs everything together and did a brilliant job of all the construct and get everything here, our sim manager and an ED nurse as well. Thank you all. Can we have some applause, please, for the team? The other thanks, if I may, Chris was a foundation member of helping me construct some of those scenarios and making sure that they sat true and felt true for you. Thank you so much for all of your great company over the last couple of months.
Thank you so much for your expertise in constructing the scene.
Jess Stokes-Paris, able to fit in as a chair, join me and keep me on track and do a beautiful job of getting everything we can out of these three amazing women. Thank you so much, Dr. Sarah Yong, Dr. Nada Hamid, Associate Professor Nada Hammond, is that right?
Yes.
Professor Zoewana, thank you so much for your expertise and coming and speaking to us today.
Thank you.
Do you want to wrap?
Thank you so much, everybody, for your engagement on Twitter. I can see that there's some reflections and thoughts there. Thank you for joining us after a wild night last night. Some of us are fresher than others. So with that, we're going to close. We'll be back here soon. Go have your morning tea, have some more coffee, and we look forward to joining you after the break.
Thank you.